Approach to Inherited Neuropathies. Jody Warman-Chardon, MD, MSc. Neuromuscular Fellow, McGill University. Neurogenetics Fellow, University of Ottawa. Objectives: develop approach to inherited neuropathies. Appropriate history. Relevant physical exam. Review of electrodiagnostic testing. Develop appreciation for benefits and erroneous conclusions due to genetic testing. At the end, discussion of career or fellowship options if you would like. Please provide feedback, written or oral, positive and especially negative. Disclosures. No disclosures. Quiz. HMSN patients usually have primarily positive sensory symptoms at onset TF. With RAS on focused exam, it is necessary to review symptoms of visual changes, hearing loss, dysphagia and hoarseness TF. GJB1 is most common mutation causing inherited neuropathy TF. Patients with HMSN most often have decreased amplitudes and preserved conduction velocities and latencies on NCS-TF. Case X 65-year-old man, diabetic, smoker, alcoholic. 4-year history of sensory loss in his feet. Exam, MS, CNN. Motor, Best cavus, distal weakness, length dependent. Sensory, distal PP decreased to ankles, vibration decreased to M. Reflexes, 1 plus some reflexes except absent Achilles. What other information do you need? Clinical approach to any neuropathy. HX. Negative motor symptoms: weakness, fatigue and wasting. Positive motor symptoms include cramps, twitching and myokymia. Negative sensory symptoms: hypesthesia and gait abnormalities such as ataxia. Positive sensory symptoms include burning or lancinating pain, paresthesias, buzzing, tingling. Alport and Sander, Continuum, 2012. Clinical assess for acquired causes. Exposures with occupation, possibility of toxic exposures to solvents, glues, fertilizers, oils, and lubricants. Sexual history. Recreational drug use. Excessive alcohol intake. Dietary habits. Smoking. Alport and Sander, Continuum, 2012. General PMHX, RO acquired. Medical, FHX, neuropathy focus, endocrinopathy, DM, hypothyroidism, renal insufficiency, hepatic dysfunction, CTD, and cancer. Surgical history, bariatric surgery, multiple orthopedic procedures, and multiple surgeries for entrapped nerves. Medication list, temporal, heart, chemotherapy, ABCs, herbal, etc. RAS, rash/skin changes, arthralgias, dry eyes and mucous membranes, orthostasis, GI, and constitutional symptoms, fever, weight loss, night sweats. Alport and Sander, Continuum, 2012, family history. Not just no neuromuscular conditions. Unless clearly acquired cause. Draw pedigree. 3. Clinical clues to inherited neuropathy. Anysymmetric, generalized polyneuropathy, plus HNPP. Family history. Symptoms less obvious to patient. Lack of positive sensory symptoms. Early age at onset, delayed milestones/development. Ankle weakness, difficulty skating, stumble, running difficulties, balance difficulties versus later adult onset. Associated skeletal abnormalities. Foot deformities. Scoliosis. Very slowly progressive. Lower, 10 years delay upper extremities, versus CMT1D. Siskind and Shai, Seminars in Neurology, 2011. Alport and Sander, Continuum, 2012. Causes of negative family history. Family data are frequently not available, incomplete, or unknown. A genetic cause is not ruled out. Initial sporadic mutation. Expression can be variable. Penetrance incomplete. Late onset disease. Family members available for study may be presymptomatic. Older relatives may have other comorbidities that confound the phenotype. Older relatives may also pass away before evaluation. Lawson and Garib-Shahi, Seminars in Neurology, 2010. Pathophysiological Approach. Suter and Shearer. Nature Reviews Neuroscience, 2003. Neuropathy is the sole or primary part of the disorder. Charcot-Marie-Tooth disease, CMT equals hereditary motor sensory neuropathy, HMSN. Hereditary neuropathy with liability to pressure palsies, HNPP. Hereditary sensory and autonomic neuropathies / hereditary sensory neuropathies, HSN. Distal hereditary motor neuropathies, DHMN. Hereditary neuralgic amyotrophy, HNA. Riley and Shai, J. Neurosurge Psychiatry, 2009. Neuropathy part of a widespread neurological or multisystem disorder. Familial amyloid polyneuropathy. Disturbances of lipid metabolism. Porphyrias. Disorders with defective DNA. Neuropathies associated with mitochondrial diseases. Neuropathies associated with hereditary ataxias. Riley and Shai, J. Neurosurge Psychiatry, 2009. CMT. Charcot-Marie-Tooth disease, CMT, disease equals hereditary motor sensory neuropathy, HMSN. Encompasses inherited neuropathies that demonstrate both genetic and phenotypic heterogeneity. IEPMP22, CMT1A, CMT1E, HNPP, early onset CMT, CMT3, previously known as Degerin-Sottis, congenital hypomyelinating neuropathy. CMT results from mutations in more than 50 genes expressed in Schwann cells and neurons causing overlapping phenotypes. Choi et al. Human Mutation, 2012, Complex CMT Genetics 60% of all CMT equals CMT1. 80 to 90% is CMT1A with PMP22 duplication point mutation. CMT. Classic clinical phenotype, length-dependent degeneration characterized by distal sensory loss and weakness, deep tendon reflex abnormalities, and skeletal deformities, foot, scoliosis, versus CMT plus syndromes. Optic atrophy, cataracts, glaucoma, deafness, dysphagia, respiratory, UMN etc. Patsko and Shai. Neural Neurosci 2011. Patsko and Shai. Neural Neurosci 2011. Electrodiagnostic studies, classic. Demyelinating. Decreased conduction velocity, less than 38 m/s. Conduction velocities. Uniformly slow in all nerves, mean 17 to 20 ms. Onset before clinical signs appear. Usually no abnormal temporal dispersion or conduction block, does not equal HNPP. I.e. CMT1AD and 4, are intermediate. Much less common. NCS velocities between 25 to 35 ms. Equals dominant or recessive intermediate CMT. Axonal. Electrodiagnostic, usually axonopathy. Median NCV. Velocity, slightly decreased, greater than 38 ms. MAP amplitude, reduced. SNAP amplitude, reduced. EMG, denervation in distal muscles. I.e. CMT2AD and 4, are Shai-M inherited peripheral neuropathies. Continuum. 2011. http://neuromuscular.wasl.edu/time/hmsn.html accessed September 15, 2012. Current organization of CMT. CMT1 equals AD demyelinating less than 38 ms. CMT2 equals AD actional greater than 38 ms. CMT3 equals no longer used. Previously Degerin status. CMT4 equals R demyelinating or axonal. Previously Refsum disease, but now Refsum not considered part of CMT. X-linked. Dominant intermediate, meaning CV between 25 to 35 ms. Patsko and Shai, continuum 2012. Shai M. Inherited peripheral neuropathies. Continuum. 2011. Demyelinating nerve pathology. Approach to CMT genetic testing. Greater than 80% PMP22, MPZ, GJB1, MFN2. Siskind and Shai, Seminars in Neurology, 2011. Patsko and Shai, Continuum 2012. Approach to CMT testing. Siskind and Shai, Seminars in Neurology, 2011. Hereditary neuropathy with liability to pressure palsies, HNPP. Usually due to PMP22 deletion, versus duplication with CMT1A. Clinical features. Transient and recurrent motor and sensory non-neuropathies, usually at entrapment sites, such as the carpal tunnel, ulnar groove, and fibular head. Duration, last hours, days or weeks or occasionally longer. HNPP can progress to long-term peripheral neuropathy phenotypically indistinguishable from CMT1. Siskind and Shai, Seminars in Neurology, 2011. Hereditary sensory and autonomic neuropathies / hereditary sensory neuropathies, HSN. Distribution, distal greater than proximal, symmetric, legs greater than arms. Sensory loss. Pain and temperature, small fiber. Large fiber loss also occurs. Progressive. Spontaneous sensations. Lancinating pains, burning. Autonomic and reflex loss. EDX studies usually only useful later in disease. www.neuromuscular.wasl.edu/sensory-small.html #1 accessed Sept 13, 2012. Patsko and Shai, Continuum, 2012. Distal hereditary motor neuropathies, DHMN. Heterogeneous group of diseases with length-dependent predominantly motor neuropathy. Plus/minor sensory abnormalities and are a significant upper motor neuron component. Often an overlap with CMT2 and with juvenile forms of ALS and HSP. Roser et al., Neuromuscular Disorders, 2012. Why would you perform genetic testing in CMT? Family planning and counseling. Diagnostic certainty. Relevance of unusual clinical features. Avoidance of potential iatrogenic toxicities. Scientific study. Lawson and Garab-Shahi, Seminars in Neurology, 2010. To choose no genetic testing. Identification of a mutation in a presymptomatic or mildly affected individual. Social stigmatization. Selection of appropriate and rational testing. Cost. Genetic heterogeneity. Lawson and Garab-Shahi, Seminars in Neurology 2010. Causes of negative genetic testing. Disease may be heterogeneous and the wrong gene has been tested. Techniques used may be insufficiently sensitive to detect the causative mutation in that individual/family. Mutation of unclear pathogenic significance may be found. Eccles, Practical Guide to Neurogenetics, 2008. Inheritance pattern. 45-year-old male with large fiber sensory loss, with myoclonus and hearing loss. Mitochondrial. Mitochondria are almost always inherited from the mother. If a female has a mitochondrial trait, All of her offspring inherit it. If a male has a mitochondrial trait, none of his offspring inherit it. Complex phenotype, heteroplasmy. Mitochondrial inheritance not followed if nuclear mutations cause mitochondrial dysfunction. Inheritance pattern: 12-year-old female with slowly progressive sensory loss in feet hands with 5 weakness in LE, palpable peroneal nerves. Demyelination pattern in EDX. Autosomal recessive. Affected offspring are usually born to unaffected parents. Appears in both sexes with equal frequency. Trait tend to skip generations. When both parents are heterozygous, approximately 1/4 of the progeny will be affected. Appears more frequently among the children of consanguineous marriages. Inheritance pattern: 5-year-old boy with progressive, length-dependent sensory and motor signs with NCS demonstrating demyelination. Autosomal dominant appears in both sexes with equal frequency. Both sexes transmit the trait to their offspring. Does not skip generations, but penetrance may not be 100%. Affected offspring must have an affected parent unless they possess a new mutation. When one parent is affected, het, and the other parent is unaffected, approximately half of the offspring will be affected. Unaffected parents do not transmit the trait. Inheritance pattern: 18-year-old boy with demyelination and SM nerves on biopsy and progressive weakness and sensory loss, sisters and female cousins less affected, X-linked dominant. Both males and females are affected, often more females than males are affected. Does not skip generations. Affected sons must have an affected mother. Affected daughters must have either an affected mother or an affected father. Affected fathers will pass the trait on to all their daughters. Affected mothers if heterozygous will pass the trait on to half of their sons and half of their daughters. Inheritance pattern: 30-year-old male with 18-year history of progressive distal LE weakness, now complaining of more hand weakness. Mother has high arches and no weakness. X-linked recessive. More males than females are affected. Affected sons are usually born to unaffected mothers, thus the trait skips generations. Approximately half of carrier mothers' sons are affected. It is never passed from father to son. All daughters of affected fathers are carriers. Inheritance pattern: for the sake of completeness. 30-year-old male, thought he was in the urology clinic, mistake with neurology clinic by the clerk, due to infertility. Y-linked dominant. Only males are affected. It is passed from father to all sons. It does not skip generations. Traits on the Y chromosome are only found in males, never in females. The father's traits are passed to all sons. Dominance is irrelevant. There is only one copy of each Y-linked gene, hemizygous. Quiz. HMSN patients usually have primarily positive sensory symptoms at onset F. With RAS on focused exam, it is necessary to review symptoms of dysphagia and hoarseness, etc. T. GJB1 is most common mutation causing inherited neuropathy F. Patients with HMSN most often have decreased amplitudes and preserved conduction velocities and latencies on NCSF. Summary: hereditary neuropathies can easily be misdiagnosed as acquired due to negative or incomplete family history. Hereditary neuropathies exhibit both genetic and phenotypic heterogeneity. Hereditary neuropathies have important consequences for prognosis, familial consequences, and future molecular therapies.